Good morning. Thank you for the invitation. We'll discuss about controversies in the management of DKA and HHS. For this, we'll first quickly go through definition, pathophysiology, prevention and management of DKA and HHS, and then go to specific questions. The diagnostic criteria for DKA as per RSSDI include hyperglycemia, acidosis, ketosis, and presence of an iron gap. Other associations, including American Diabetes Association, have very similar criteria. Not to forget that many patients do not meet all the criteria for DKA, and that ketonuria or significant ketosis with beta-hydroxybutyrate very high are also seen in starvation and in keto diet. And most outcomes are worse in individuals who have more severe dehydration and osmolality. As regards HHS, it requires hyperglycemia, and absence of significant acidosis, absence of significant ketosis, and of course presence of significant hyperosmolality. ADA also has the mental status criteria in it. Pathophysiology of diabetic ketoacidosis requires an elevation of counter-regulatory hormones plus a severe insulin deficiency and excess glucagon, all of which leading on to excess glucose production, increase fat breakdown. This excess glucose production is increased by further supply of free fatty acids from fat breakdown, and this causes glycosuria, dehydration, and feeds back to worsening of counter-regulatory hormones. On the other hand, excess free fatty acids also produces substrate for ketone production that happens in the absence of insulin and in presence of anti-insulin hormones, once again feeding back to counter-regulatory hormones. Acidosis and glycosuria both lead on to significant loss of electrolytes, and all this leading on to diabetic ketoacidosis. On the other hand, in hyperosmolar hyperglycemic state, the insulin deficiency is not severe, and this small amount of insulin prevents ketone production and therefore prevents acidosis. The aims of treatment include dehydration, because these patients are in acute kidney injury or would develop acute kidney injury if not adequately treated. Restoring electrolyte balance, especially that of potassium, and allowing time for ketosis to resolve by treating hyperglycemia by provision of insulin and if required glucose, without of course causing hypoglycemia. This requires frequent patient monitoring, and at the end we have to identify what caused diabetic ketoacidosis so this does not happen again. Intravenous fluids should be provided to correct fluid deficit within the first about 24 hours. General guidelines would say about 1 liter first hour, etc. Give 3 liters of non-glucose containing fluids in 3 to 6 hours and 3 liters of glucose containing fluids over next 6 to 18 hours. The examples of fluids are given here, and we'll discuss this some more down the line. Patients may require more fluids if there is more dehydration, for example in HHS or in patients with DKA who also have hyperosmolarity of that degree. As regards electrolytes, routine replacement of phosphate and bicarbonates is not recommended. And about potassium, at various degrees of potassium we have to replace potassium, except if potassium is very high, we should not be replacing potassium. Insulin should be given first and potassium supplementation started when potassium is normalized. On the other hand, if potassium is low, then insulin is not started and potassium is given first. Once potassium is normalized, then insulin is started. Insulin is usually used intravenous using regular insulin. We start at 0.14 or 0.15 unit per kilogram per hour, or if started at 0.1 unit per kilogram per hour, started after a 0.1 unit per kilogram bolus. The subcutaneous basal insulin should be started as soon as possible, as long as there is no suspicion of it not being absorbed adequately, for example hypotension or pressors being used. We shouldn't be waiting for long-acting insulin for transition time or for closing of gap, etc. The insulin adjustments should be made by increasing insulin if the glucose is not falling by about 50 to 75 points within the first hour, and this should be increased every hour till the time glucose comes down below 200 milligram per deciliter. Mostly this fall is adequately seen. In addition, insulin adjustment is required when glucose concentrations come back to below 250 or below 200 milligram per deciliter till the time DKA resolves, and at that time the insulin infusion rates are reduced to about 1/5 or so, and at the same time dextrose containing fluid is added. This is the protocol that we use to adjust insulin and dextrose, and this is a nurse-driven protocol, so the glucose concentration can be maintained between 200 to 250 or 150 to 250 milligram per deciliter. Management of HHS is very similar to diabetic ketoacidosis, except there is more fluids. We switch to dextrose containing fluids at about 300 milligram per deciliter higher levels. Target glucose is 200 to 300 milligram per deciliter. Bicarbonate has no role, and we don't give bolus insulin in hyperosmolar hyperglycemic state. Let's go to the specific questions about insulin, subcutaneous versus intravenous. This is a randomized control trial comparing hourly or 2-hourly subcutaneous aspart insulin to intravenous regular insulin in the 3 colors as shown here. As you can see, glucose, bicarbonate, pH, beta hydroxybutyrate or free fatty acids were not different in the 3 groups, implying that subcutaneous insulin therapy can be used for treatment of diabetic ketoacidosis. In a meta-analysis, 3 trials, there were no deaths reported. There was no difference in time to resolution of diabetic ketoacidosis, time to reach glucose less than 250 milligram per deciliter, episodes of hypoglycemia or hospital stay. Therefore, subcutaneous insulin management can be used for management of diabetic ketoacidosis. We give basal insulin as soon as possible or whenever the next dose is due, or if it is new, a weight-based dosing. Rapid-acting insulin should be given a bolus 0.3 unit per kilogram and then given 0.2 unit per kilogram every 2 hours, which is about the same as 0.1 per hour when used intravenous. When glucose comes down below 250 milligram per deciliter, this dose is reduced to about half to 1/5 until, of course, DKA resolves. The next question is where to manage these patients at home, in hospital or in ICU. At our center, we admit patients to ICU if there are indications of admission to ICU as mentioned here. If patients are sick enough but not sick enough to get to ICU, like have hypokalemia and require cardiac monitoring for potassium replacement, and there is significant acidosis, we put them to what is called progressive care unit or a step down unit from ICU. Otherwise, we admit these patients in general ward. If the patient are alert, vitals are acceptable, potassium can be corrected without cardiac monitoring, and the acidosis is mild. In addition, most people with type 1 diabetes will tell you that they manage their ketosis always at home if they are well educated. How to use supplemental insulin for glucose, supplemental insulin for ketosis, when to measure ketones, how to keep their fluids down, and if they are not keeping the fluids down, of course, they have to come to hospital. If there is no other reason to hospitalize, they should not be hospitalized for management of ketosis. Hyperosmolar hyperglycemic state almost always require hospitalization to some sort of intensive care unit. Next question is normal saline versus balanced electrolyte solutions for initial resuscitation of a patient with diabetic ketoacidosis. For this, we will discuss one randomized controlled trial and a meta-analysis. This trial from PGI Chandigarh shows that patients who received plasma light compared to those who received saline had similar primary outcome, that is composite of acute kidney injury, or individual components of acute kidney injury or the secondary outcomes of acute kidney injury. Overall, the time to resolution of DKA was not different in those who received plasma light and compared to saline. In meta-analysis, it has been shown that time to resolution of DKA is about 3 to 4 hours less if balanced electrolytes are used. Length of hospital stay is less by about 1 day in those who we have used balanced electrolytes for initial resuscitation, and the bicarbonate resolves sooner in those who received balanced electrolytes. However, the death, the absolute resolution of diabetic ketoacidosis, acute major kidney injury or overall kidney injury are no different in those using balanced electrolytes or saline. Therefore, the balanced electrolyte solution has uncertain effect on mortality, an uncertain effect on acute kidney injury or overall resolution of DKA, but is associated with shorter time to DKA resolution, shorter hospital stay, and lower post-resuscitation sodium chloride and higher post-resuscitation serum bicarbonate. So pending further data, this meta-analysis recommends using balanced crystallized solution, preferring that over saline. However, I would say that saline will work nearly as well, at least for the time being, at least in our situation, because we have bags of saline which are pre-mixed with potassium and we don't have to mix it in the hospital. Next question is the relationship between cerebral edema and rate of fall of glucose. In a nationwide study recently published from US, 0.03%, only 0.03% of patients admitted with DKA and HHS developed cerebral edema. Cerebral edema was of course associated with more severe disease, higher mortality, longer hospital stay, and higher cost. Good old days, the pathophysiology of cerebral edema went like this. Hyperosmolarity causes increased intracellular osmolytes. Treatment of diabetic ketoacidosis reduces hyperosmolarity in the blood vessels. This pushes water into the cells, which causes cellular swelling and edema, increased intracranial pressure, herniation, and cerebral injury. Beautiful hypothesis, except that this is not true. Reasonably good data analysis, for example, this randomized controlled trial of children with diabetic ketoacidosis receiving slow half normal, slow normal, rapid half normal, or rapid normal saline shows there is no significant difference between mental status during diabetic ketoacidosis treatment, rates of clinically apparent cerebral injury, or tests of memory and IQ 2 to 6 months after recovery from diabetic ketoacidosis. On the other hand, in those who had more severe diabetic ketoacidosis, as evidenced by pH or PaCO2, rapid fluid infusion was associated with faster, not slower, faster improvement in memory, more rapid normalization of anion gap and PaCO2, and with an increased frequency of hypercalemic acidosis, as one would expect with normal saline infusion. This is some data showing that DKA occurs the cerebral edema occurs more often in those who have more severe dehydration, more severe acidosis, but the rate of fall is actually negatively associated, implying thereby when treated fast, the cerebral edema occurs less often. Therefore, the current understanding of hypothesis is that diabetic acidosis causes dehydration, hypocapnia, decreased cerebral blood flow. Treatment of diabetic ketoacidosis leads on to an elevated cerebral blood flow. This hyperemia is associated with vasogenic cerebral edema. In addition, diabetic ketoacidosis leads on to increase in inflammatory factors, and it is diabetic ketoacidosis which leads to vulnerability of brain to ischemic injury and cerebral edema, not the treatment of diabetic ketoacidosis. This is a similar story to what happens in peripheral arterial disease. This is a picture I've taken from Dr. Cummings' website, where a patient presents with pre-gangrenous situation, undergoes revascularization, and with that develops revascularization syndrome or reperfusion syndrome, where there is pain, decreased pulses, redness of the skin, edema, decreased sensation, and this completely clears off after a few days. The next question is about end-stage kidney disease and heart failure in DKA. This data of 307 patients, out of which about 22% had end-stage kidney disease and were on hemodialysis over 11-year period, shows that end-stage kidney disease with patients on hemodialysis have a higher rates of hypoglycemia, including severe hypoglycemia, develop volume overload more often, require mechanical ventilation more often. The length of hospital stay is higher, though there was no difference in hospital mortality. Now the data on DKA and heart failure, and this in diastolic heart failure. About 1.5% of patients who admitted with DKA had diastolic heart failure. Diastolic heart failure is associated with non-statistically significant increase in hospital mortality. It's associated with longer hospital stay, higher cost of treatment, and more episodes of non-ST elevation MI. There is more chance of acute respiratory failure, as one would expect. And the sepsis, though not statistically significant, was more in those who had diastolic heart failure. Looking at the outcomes of diabetic ketoacidosis in heart failure with reduced ejection fraction. This is a retrospective study, actually only abstract published. I have not seen the original publication yet. About 2,200 patients out of about 200,000 patients with diabetic ketoacidosis had heart failure with reduced ejection fraction. They required more often intubation, had longer hospital stay, had higher costs and higher mortality, though some of the data was not provided in the abstract. Therefore, in situations where there is end-stage kidney disease or heart failure and patient has DKA, we should use smaller boluses, and further fluid resuscitation should not be based on a protocol but should be based on fluid resuscitation guided by the assessment of fluid status. We should use smaller doses of insulin and not forget that these patients may look peripherally overloaded while they are intravascularly depleted. A previous weight, prior echo findings and fluid status may be helpful. It is still recommended that normal saline or potassium should be used in these patients. And of course, if there is any signs of worsening hemodynamics, these patients may require hemodialysis or vasoactive drugs sooner.
To summarize, therefore, we discussed the criteria for diabetic ketoacidosis in HHS. Diabetic ketoacidosis is defined by hyperglycemia, ketosis, and acidosis, and HHS as absence of significant acidosis and ketosis, and presence of significant hyperosmolarity. We discussed pathophysiology of DKA, where there is severe insulin deficiency, and that of HHS, where insulin deficiency is not that severe. But in both conditions, counter-regulatory hormones play a very important role. We discussed also the treatment plan for these situations, where we have to correct hydration, restore electrolyte imbalance, and correct hyperglycemia or ketosis as the condition may be. This requires frequent patient monitoring, and we have to find out the cause so that it does not happen again. We also discussed that intravenous regular insulin works as well as subcutaneous regular insulin and subcutaneous shorter acting insulin every 1 hour or every 2 hours. If we use subcutaneous insulin, we should start basal insulin as soon as possible, provided the blood pressure allows. And rapid-acting insulin is used every 2 hours and therefore double the dose of what we would use every hour in intravenous insulin plan. We then discussed that ketosis can be managed at home if patient knows how to handle ketosis. We discussed the patient may require admission to general care if the patient is otherwise stable, but if patient requires cardiac monitoring, to progressive care unit, and if the patient has indications to get into ICU, then into the ICU. We discussed also that between saline and balanced electrolytes, for example plasma-lite or ringer lactate, there are no major differences, though meta-analysis implies that using balanced electrolytes would lead on to a sooner clearance of ketoacidosis as well as a shorter hospital stay. We discussed that the good old theory of how diabetic ketoacidosis leads to edema by quick recovery from hyperglycemia is not correct, and that diabetic ketoacidosis itself causes situation which leads on to cerebral edema. And if anything, data implies that quicker recovery of glucose leads on to decreased chances of cerebral edema. And at last, we briefly discussed about managing DKA and HHS in end-stage kidney disease and heart failure, where we should use smaller fluid amounts, smaller insulin. Remember that there is fluid overload in third spacing, whereas the volume in the blood vessels is less. We discussed that previous data on weight and echo findings may be helpful, and that we should constantly monitor the hemodynamics, etc., and if required, go for hemodialysis and vasoactive drugs. Thank you so very much for patient listening.